So now Dr. Ashley Lane is one of our amazing young faculty, as part of our liver transplant team as well. She splits her time between the university and also the Rocky Mountain Regional VA. We have given her the task of speaking today on drug-induced liver injury, emerging suspects. So take it away, Ashley.
Thank you, Amanda. Can you guys see my slides and hear me okay? Perfect. All right. Well, good morning. I'm honored to be able to present today on an important topic that I think is becoming more prevalent in our clinical care. So something that we're all going to see more often and very important to know what to do with. I have no disclosures. My goals for the talk today for you guys are to highlight the risk of immune-mediated hepatotoxicity with immune checkpoint inhibitors, review how hepatotoxicity with immunotherapy presents, how we should work it up, and then review management options and also long-term outcomes with patients with these issues. So I wanted to start by introducing a case of mine, a patient I met last year to tie into my talk. So I have a 54-year-old male who began immunotherapy with ipilimumab and nivolumab for metastatic melanoma in late May of last year. And you can see at the bottom, I've kind of outlined his liver tests after he started therapy. So before therapy, his liver tests were normal. As he began therapy, he was noted to have a mild hepatocellular liver injury on surveillance laboratory testing done before his infusions. And then in September, a couple months after he started immunotherapy, he developed a severe hepatocellular liver injury with jaundice that prompted admission for further evaluation and management, which is how I met him. So immune checkpoint inhibitors, why is this an important topic to discuss? So these are a new class of anti-cancer drugs that are associated with significant response and improved overall survival rates across many different tumor types, including hepatocellular carcinoma, metastatic melanoma. It is becoming the standard of care for treatment of many advanced malignancies, so we're going to be seeing this more often. It's associated with immune-related adverse events, with hepatotoxicity being one of those things, and hepatotoxicity actually occurs in up to 16% of patients receiving immunotherapy. And it's really important that we know how to recognize this complication and know how to manage it to prevent further complications. So the immune checkpoint inhibitors I'm going to be talking about today are monoclonal antibodies that target CTLA-4, PD-1, and PD-L1 with the overall goal of therapy to restore tumor eliminating function of host T cells. So here are the current FDA approved immunotherapy agents in the United States. It began with ipilimumab in 2011, which is a CTLA-4 inhibitor, and it's grown to expanded to target PD-1 and PD-L1 targets as well. So when we refer to hepatotoxicity of immune checkpoint inhibitors, there's a couple ways it's described. So we can call it a hepatic immune-related adverse event, but more commonly we call it an immune-mediated hepatitis. And it's technically a drug-induced liver injury, although it's more a liver injury in an indirect pathway. So it's really our immune system that gets triggered to attack hepatocytes and not a direct drug toxic effect. So the severity of injury can range from being asymptomatic or mild to life-threatening, and people can actually develop acute liver failure rarely from these agents. And the National Cancer Institute created this common terminology criteria for adverse events, which were initially used in clinical trials to monitor adverse events to these agents, but also are used now to guide and grade the severity of injury to help us know what to do with the injury. So you can see on this chart, the National Cancer Institute basically graded the injury based on transaminases, alkaline phosphatase, GGT, and bilirubin, and graded on variables of how high the liver tests are based on the upper limit of normal. This contrasts with the DILI network severity index, which includes INR and also includes clinical factors such as hepatic encephalopathy and whether the patient is admitted. So I wanted to highlight the incidence of hepatotoxicity with these agents and also the incidence of more severe hepatotoxicity, so grade 3 and 4. So ipilimumab, high dose in particular, is associated with the highest incidence of hepatotoxicity and also the highest incidence of grade 3 to 4 hepatotoxicity, followed by combined therapy with ipi and nivo, and then followed by durvalumab. So how does immunotherapy trigger hepatotoxicity? So this isn't well understood, but it's thought to be due to increased autoimmunity to hepatocytes because of the T cell activation from these drugs. There are some clinical factors that are emerging that may be associated with this injury. So patients with prior autoimmune disorders going into treatment are more likely to have immune-related adverse events from these agents. Typically, ipilimumab, that's where the most data is for that. And a third of patients with ipilimumab, if they have underlying autoimmune disease, will actually have a flare of their disease requiring treatment. But in the literature, it's mainly patients with rheumatologic disorders, and there have been no patients reported with underlying autoimmune hepatitis that have had this issue. So patients with prior immune-related adverse events from ICIs are more likely to have, again, immune-related adverse events from a different class of immune checkpoint inhibitors, and this risk may be dose-dependent, as I illuminated with ipilimumab. And combined use like ipi and nivo increases the incidence and severity of liver injury potentially. The literature suggests that having pre-existing autoimmune hepatitis or positive autoimmune markers has not been associated with immune checkpoint inhibitor adverse events, including immune-mediated hepatitis. So how does it present? So most patients are actually asymptomatic, and it's common practice to get baseline liver tests and then routine laboratory testing before infusions. And most of the time it's picked up on routine laboratory testing. Based on the available literature, the most common pattern of liver injury is mixed, and it's typically mixed at onset and hepatocellular at peak. I personally have seen it's more hepatocellular, but it can vary. So like we talked about, the injury can be mild and asymptomatic to rarely patients showing up with fulminant hepatic failure. And the average onset of the immune-mediated hepatitis is 1 to 3 months from the initiation of treatment, or 1 to 3 doses. With IPI, you can see a fever. And I think it's important to highlight that in contrast to autoimmune hepatitis, most cases of immune-mediated hepatitis, when tested, they don't have autoimmune markers. And if present, it's typically an ANA and a low titer. So when you're asked to evaluate someone with abnormal liver tests on immunotherapy, what do you want to do to evaluate it further? So ultimately, like any drug-induced liver injury, it's a diagnosis of exclusion. Really important to pursue an appropriate serologic evaluation to determine if there's another cause of an acute hepatitis. I think it's important to point out that some of the immune checkpoint inhibitors can cause a myocarditis or myositis. So if you see someone with a significant hepatocellular injury where the AST is greater than the ALT, I think that's something that you need to keep in the back of your mind. It's also important to note, have they been on other chemotherapeutic agents before where hepatic veno-occlusive disease would be a consideration as well. Imaging, I think it's important to make sure that the hepatic vasculature is patent and they don't have any metastatic disease to the liver, because these are generally patients who do have advanced malignancies where this should be a consideration. Imaging looking directly at DILI from immunotherapeutic agents is not sensitive or specific. There's no specific findings for it. At most, with really severe cases, you're going to see a mild periportal lymphadenopathy or edema and potentially hepatomegaly. So the use of biopsy varies in the literature, and it's a little controversial, but the current guidelines suggest you can consider it in grade 2 injury or above, mainly to exclude other causes of liver injury, and if you wanted to confirm the diagnosis of immune-mediated hepatitis, or also to determine how severe the injury is. And there's no pathognomonic histologic findings on biopsy. So if you do biopsy someone, what are you going to see? So this is actually my patient that I saw in the hospital initially. So this is liver biopsy. So the most common theme that has been reported in the literature is an acute hepatitis with lobular and portal-based inflammation with acidophil biopsy bodies and some necrosis. But really the injury can vary between the different immune checkpoint inhibitors. So if you look at this low-grade field of the liver biopsy on my patient, if you look at the portal tract, which is illuminated by the black arrow, and the lobule, which is the red arrow, you can see even from low power, there's a dense inflammatory infiltrate, which appears blue. So there's a lot of busy things happening on the slide. So on the same patient, when you look at more high-powered images, so on the left looking at the lobule, on the right looking at the portal tract. So on the left, you'll notice there's a lobular hepatitis characterized by a chronic inflammatory infiltrate, which is predominantly lymphocytes, those little blue dots. And then in the black circle, you see some hepatocyte dropout. And with the red arrow, you can see an apoptotic body. On the right, so that's looking at a portal tract. So you'll see a portal inflammatory infiltrate, again, mostly lymphocytes, and the red circles are neutrophils. And if you look at the interface between the portal tract and the lobule, which is shown by the dashed line, you see that there's a lack of a plasma cell-based infiltrate, which you would see with autoimmune hepatitis. So there are many clinical and pathologic differences between IMH and autoimmune hepatitis that I wanted to point out. So in IMH, there's no female predominance, and only a minority of patients are going to have positive autoimmune markers. And if so, again, it's going to be a low titer positive ANA. Biopsies, when done, show little to no plasma cell infiltrate. And in IMH, it's typically a self-limited process, so it won't recur after the immune checkpoint inhibitor is withdrawn. So you've excluded other causes, and you're really concerned that the patient you're seeing has immune-mediated hepatitis related to their ICI therapy. So what do you want to do about it? So there's not a lot of data to guide management, and current societal guidelines are really just based on expert consensus. I think it's really important that you work closely with their primary providers, especially in oncology, to help come up with a good plan of care. So the current oncology guidelines, which I'm summarizing here, base their therapy on the grade of severity that we talked about earlier. So in grade 1 injury, they suggest continuing the immune checkpoint inhibitor and just continuing to monitor closely. Once you reach grade 2 injury, they recommend instituting weight-based corticosteroids and withholding the immune checkpoint inhibitor and just monitoring closely. If the liver tests return back to baseline or grade 1, they suggest you can restart the immune checkpoint inhibitor and continue to monitor. With grade 3 injury, again, they recommend instituting weight-based steroids. You can tell it's a little bit higher dose. This is where it differs. So in grade 3 and 4 injury, they recommend permanent discontinuation of the immune checkpoint inhibitor. So the AASLD, there's a recent systematic review that was published that included a proposed management algorithm for these patients, since we're seeing it more often. And this algorithm bases treatment guidelines on grade, just like the oncology guidelines. And they made the recommendations based on their systematic review from the prior published society guidelines and also from FDA recommendations. So it kind of mirrors the oncology guidelines. So with grade 1 injury, they suggest you can continue the immune checkpoint inhibitor and continue just to monitor the liver test really closely, and no immunosuppression is necessary. Once you reach those more higher grade injuries, grade 2 through 4, they suggest you should hold the immune checkpoint inhibitor, monitor the liver test with a frequency varying based on the severity of the liver injury. And then if the liver tests don't improve or worsen, starting weight-based corticosteroids as outlined. With grade 2 injury, if the liver tests improve to baseline or grade 1, they suggest you can continue the immune checkpoint inhibitor. In grade 3 injury, they suggest if the liver tests improve as well and you taper the steroids, you can consider resuming the immune checkpoint inhibitor or switching from CTLA-4 therapy to anti-PD-1 or PD-L1 therapy. With more severe injuries that don't respond to steroid therapy, they suggest you can consider starting a steroid-sparing agent. Our current general practice at the university is to use mycophenolate, but you can see they have a bunch of different options outlined, and the oncology guidelines actually recommend considering infliximab. I wanted to highlight as well, just because of the varying differences in different guidelines, the DILI network and liver tox is a little more vague on what to do. So in different recommendations, they state that there's no information, really little information on the safety of restarting ICIs after the occurrence of liver injury. And in some instances, therapy can be restarted safely after the injury resolves, but in other instances, immunosuppressive therapy is required. They do specifically say in regards to ipilimumab that after a severe injury requiring steroid therapy, they don't recommend re-challenging because it's typically followed by the recurrence of the liver injury. So general outcomes, so the majority of cases actually resolve spontaneously or respond to immunosuppressive therapy. And resolution is generally seen in 5 to 9 weeks after management is initiated. People do die from immunotherapy-induced hepatotoxicity, and up to 0.2% of patients actually develop acute liver failure. When looking at whether if immunosuppression is started, whether that was associated with worse outcomes in regards to their oncologic care, there was one retrospective study that showed that immunosuppression was not associated with an impact on patients' overall survival or a shorter time to treatment failure. So looping back to my patient, we did a pretty extensive serologic evaluation to make sure nothing else was going on, and his autoimmune markers were negative. We got cross-sectional imaging, which showed his hepatic vasculature was patent. There's no evidence of metastatic disease. We reviewed his liver biopsy during this talk, which showed moderately to severely active portal, periportal, and lobular hepatitis. And there was hepatocyte dropout involving approximately 5% of his parenchyma. The differential given by our liver pathologist included autoimmune hepatitis versus DILI. So he was admitted to oncology, and they initiated weight-based therapy with prednisone in divided doses. And his liver test didn't improve after about 3 days of therapy. So then we initiated mycophenolate. And over time, as I followed him as an outpatient, his liver tests kind of became stagnant as I was trying to wean his steroids. So I ended up having to escalate his steroid-sparing therapy to allow me to taper his prednisone down further. He's currently doing well. His prednisone is now stopped. And after discussing with the patient and his oncology team, we're actually starting a slow wean of his mycophenolate. So what I want you guys to take away from this talk is that immune checkpoint inhibitor use is rapidly increasing and becoming the standard of care in oncology for advanced malignancies. Hepatotoxicity is a significant adverse event associated with this therapy and can be seen in up to 16% of patients receiving this therapy. It's really important that you're able to recognize this injury and know what to do with it when you get consulted on a patient with this injury. Most cases can be managed by stopping the immune checkpoint inhibitor. Some people will require immunosuppressive therapy, but some patients actually will die from this therapy. And unfortunately, the patients who come in with acute liver failure, the majority of them have advanced malignancies where liver transplant wouldn't be an option. It's really important that you work with the patient's oncology team and primary providers to basically provide patient-specific care and adequate care for these patients. Thank you, guys.
All right, Ashley, thank you so much for a wonderful talk.